So I'm Bill Nelson, director of the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, a little bit of a journey up the road in Baltimore. And I have to tell you, at this point in the evolution of cancer care and healthcare generally in the country, I think I have one of the great jobs you can possibly have, although as you'll see as this slide evolves, it was a reasonably improbable journey. I think I spent most of my young life, I wasn't anywhere near as focused as Andreen Taylor was. I spent most of my life kicking soccer balls and playing music as I became enthralled with the idea of trying to conduct research to discover new treatments for dread diseases, and was told to do that you really need to go to medical school and acquire some degrees and credentials and the like. The absence of a pre-medical curriculum in college and these kind of things was a little bit of a barrier, and I'm not sure that the people who provided with me my education found me to be an interesting target for medical education, or were honestly interested in the sheer challenge of providing an education like that to someone like me. But what I'm here to do a little bit today is just tell you a couple stories about what we're talking about in the evolution of cancer care from the perspective of an academic cancer center, an academic medical center. As you know, as our healthcare financing system is evolving, academic medical centers are transitioning, and very quickly, to academic medical systems. And so my job at the Sidney Kimmel Comprehensive Cancer Center now is I preside over a system of cancer care that involves about 10,000 or more new patients a year that we treat, 60,000 or so visits. 2/3 of the patients that we see who are candidates for systemic therapy receive them as part of a clinical trial. It's a little bit unusual for cancer care as you think about it. And we're charged, in a sense, at an academic medical center, not just with delivering cancer care services as the highest level we can, but also delivering discoveries, the research, and discoverers, the next generation of people who are going to make the next series of discoveries. And so that's what I'd like to sort of share with you. How is that going to figure in how cancer care evolves in the country as we think about new ways to provide cancer care, new ways to finance it, and the like. And the first story I'd like to tell you is a little bit about multidisciplinary cancer care. And I think you heard a little bit earlier that when somebody hears the words, "you have cancer," there is a clock that starts ticking until the time that they are helped. A clock that literally ticks until there's a definitive treatment plan and you can get started with the treatment. All the time that clock is ticking is filled with anxiety, worry about what you have, worry about things you don't even know you might have. And there's a huge appetite to learn about the cancer that you heard about. What's going on with me? What's going to happen to me? How are we going to take this on? And a system that's now incredibly complex, Rich Shilsky talked about. Think about breast cancer. There's at least 7 different highly specialized physicians that contribute to the care of a woman with breast cancer these days. That's a lot of moving parts for a system that grew up as a ping-pong referral system. You'd see me, "oh, I'm not sure I can help you with this, go see someone else," and whatever the lag is to get an appointment, et cetera, et cetera. So we tried to build those kind of experiences around the patient with the notion that we need to get back with definitive help within 24 hours and get people in the door that everything they would need would be there. So they would leave as soon as possible with a definitive diagnosis, treatment plan, and a strategy to get the treatment started. Now that's these multidisciplinary centers that people talk about, but I have to tell you, they require a lot of work. I think at this point we operate about 7 to 10 of them at a very high level, because if you think about how you're going to staff one of these, you can't staff them with 100 people that spend most of their time twiddling their thumbs. You have to optimize these so that the function flow and what the patient needs is delivered. And it's different for different diseases. So one of the ones that works at a pretty high level has astounded us as we've looked at what we have created, and that's one that takes on pancreas cancer. And it's interesting, everyone you possibly need to see with pancreas cancer, we arrange a series of visits and education and the like, and people leave an experience like that with enormously high satisfaction scores on any survey. I have a feeling they're also exhausted. I don't even know how they fill out the survey at that point, because they walk out the door thinking they've heard everything there is to know about pancreas cancer. They've had every one of their questions answered. That's extremely important, as you heard. But what was interesting about this, as we started to follow how people have done when they came to this clinic, we learned something astounding. Now remember, these people got to us at an academic cancer center because they had a diagnosis of pancreas cancer, right? So it turns out, as we were watching, we did these analyses of all the cancers we treat and what the outcomes were. And this was just as a quality measure. Do you do well if you're treated for a cancer at our place? And you can get information off of tumor registries and the like, and they're usually survival by stage groupings and the like. And we found that in pancreas cancer, if you had stage 1 pancreas cancer at our place, half the people are alive 5 years and well. And if you take the national average, it's about 18-19%, and at other academic cancer centers, it's about 25-26% alive and well. So as we were congratulating ourselves, we did a better thing, which was to think, why is this? Why is this true? And there's some very well-known methodologic biases that enter the way you do this, particularly if you're more accurately diagnosing and staging the people you take care of. Right? So we started to look at that very carefully, and it turns out, and this is published information, that we were changing the diagnosis, stage, or grade 26% of the time when people walked in with pancreas cancer. Half the time there was unsuspected metastatic disease. 4% of the time, 4% of everyone who showed up at this multidisciplinary pancreas cancer clinic did not have the disease at all. That's an astounding thought. And you can say, how did we figure this out? Why were we able to do this? And the answer is because we can bring human capital resources to this problem that's difficult to bring outside of a large, highly specialized cancer center. We have several pathologists who do nothing but look at pancreas cancer. You can't muscle up with that kind of approach deployed out on the front lines of cancer care all across the country. So we started to think much more aggressively of how can we use this service and make it more broadly available to our health system, to our region generally. Because, as you know, ASCO that Rich Shilsky has talked about, the National Cooperative Cancer Network, there's many groups trying to come up with guidelines of care that will ensure high-level quality and cost-effectiveness. Those guidelines don't work if you don't enter them at the right place. So 1/4 of people with pancreas cancer aren't going to enter the guidelines at the right place. About 15 to 20% of men with prostate cancer aren't going to enter the guidelines at the right place. So this is something we need to figure out in an academic center, and we need to figure out ways to scale and deploy to everybody so everybody benefits. So that's one aspect of multidisciplinary care at a cancer center that's been quite fascinating to us. The second is the value of discovery. Most people think of discoveries as just expensive. We're going to create expensive care models. We're going to develop new treatments and new treatment approaches that are just going to cost a lot more money. If the discoveries lead to better outcomes, as Rich Shilsky was mentioning, they will ultimately lead to more cost-effective care, greater value in care generally. And you never know where the discoveries are going to come from. You heard a little bit about stem cell transplants earlier. There's a version of that kind of treatment approach for acute leukemia in which historically, you took the flamethrower that Rich Shilsky described for you and Andreen described for you in a personal way, and you wiped out the normal blood-forming elements, you wiped out the leukemia cells that you see here, and you got bone marrow from somebody else who didn't have a disease, and the idea is that would make the white blood cells that fight infections, the platelets that plug little holes in blood vessels, and the red blood cells that carry oxygen to the tissues. The challenge historically, and this would cure leukemia, that was been known for quite a while. The challenge, of course, was that you got a new immune system, and it's sort of the opposite or the inverse of organ rejection. For organ transplantation, this new immune system would attack the person, something we call graft, because the new blood-forming cells were the graft, versus host, the person disease. Now, graft versus host disease was a devastating complication. I think when I started, about 25% of everyone who got a bone marrow transplant for leukemia like this from somebody else, a very closely matched donor, so that the chance for the graft versus host disease would be minimized, about 1/4 of the people died from the transplant, and most of that was attributable to graft versus host disease. So this was a huge problem. Even as we got incrementally better, and what we needed was very closely matched people, and this took many people that we need to serve out of play, because you have a 1 in 4 chance to have a sibling that might be an appropriate match. Now, there's not many people who have that many siblings anymore, And so if you don't have a sibling, you would go to the National Bone Marrow Registry. The National Bone Marrow Registry is a wonderful group of people who have decided they might donate bone marrow to a stranger for bone marrow transplantation, but almost all of those people are Caucasian. So we live in a state of Maryland where 26% of everybody is African American, 4 or 5% Hispanic, and then a whole set of race and ethnicities. All these people can't benefit from this treatment because it's very hard to find a match for them. So the impetus was to make a discovery to figure out how to get rid of graft versus host disease. And a couple of years ago, when people weren't thinking about it, they figured out a way. We pretty much eliminated it from allogeneic, somebody else's bone marrow transplantation. So now it's accessible and anybody could have it. But it's made it so much safer that it started to have huge impacts on healthcare that we did not honestly even think about. The first is that it's so much safer that we can now deliver this treatment as an outpatient. This was unthinkable a decade ago. Things like bundle payment, we happily take a bundle payment for this because we know we can make money doing it, right? Because we can do it as an outpatient. We can do it with minimal cost. The second is that the toxicity is so minimized, we can go after different diseases now. So one of them that is an affliction common in our community in Baltimore is sickle cell disorder. Right? Sickle cell disorder, for some people who have it in a lot of sickle crises, need to use health services a lot. Very difficult to get the right kind of pain relief. It really ruins their life. They spend a lot of healthcare resources, and it's just a very tough disease to have. Well, that's a disease of blood-forming cells. What if we give them somebody else's blood-forming cells that don't have the sickle hemoglobin gene? So the answer is we're up to, I think, 50 now. Most of these people are completely cured. It's astounding. It's beyond what I could have possibly imagined. Completely cured, sickle disorder gone. Then you can start to say, well, wait a minute, what about diseases? Since you're getting somebody else's immune system, what about a disease where your immune system doesn't work correctly? You have lupus or multiple sclerosis. It looks like this may work for that as well. And finally, think about major organ transplantation. You're going to get somebody else's kidney or liver or heart or lungs. What if you deliver their bone marrow along with them? Can you do that? And the answer, it looks like you can probably do that. If that's the case, then there will be no need for rejection drug treatment, no need for the complications. So discoveries are going to radically change the cost of many things we do and the benefit of things we do. We need to ensure that we continue to make those discoveries. And I think that the academic centers are going to be the place where a lot of them are done. But we need to make sure that we do them in a responsible way and that we deliver them not just from the laboratory to the clinic, but from the laboratory and the clinic to health systems that can optimize their deployment so the maximum number of people can benefit. So that's a view from the cancer centers from a frustrated musician and soccer player. Thank you.